Good evening, I am Nageshwar Reddy and welcome to the AIG weekly international COVID updates. For the last 8 weeks, every Tuesday we have had an eminent international personality who's in the midst of COVID, who's been giving us updates on what's happening in different areas in Spain, in Italy, in Israel, in Belgium and so on. This evening, I am extremely glad that we have another very eminent gastroenterologist and endoscopist who is going to talk to us, Professor Amrita Sethi. Amrita Sethi had a brilliant career, and then after training at Denver, Colorado, she is currently the Associate Professor of Medicine and Director of Pancreaticobiliary Endoscopy Services at Columbia University Medical Center, New York. So New York has been, I think, the epicenter of this COVID problem. And we've heard of several COVID warriors who have fought the patients there, the healthcare workers. I'm glad that Amrita could join us here, because Amrita is not only a gastroenterologist and endoscopist, but also one of the founders of the Women in Interventional Endoscopy group, which is very active, works with a group of women. And I think we are very fortunate Amrita has agreed to address us. In fact, she's also familiar to a country she's been here. She's also been to Myanmar, where we have a large audience for this present address, and of course we look forward to listening to her. Amrita, thank you very much. We look forward to listening to you.
Thank you so much for the invitation. It's really wonderful to virtually be with all of you, since we know for a while that we won't be able to really travel outside of New York, so this is a really wonderful opportunity. And hello to all of my friends who might be watching in Myanmar, India, and all over Southeast Asia. So thank you, Nagi. So can you see my slides?
No, we are not seeing this still.
Okay, so I should share the...
Yeah, I should share it with you. Yeah, now, yeah.
Okay, perfect.
Yeah, we're seeing it now.
Wonderful. Okay, great. So, so thank you again for the opportunity to talk about COVID-19 in New York, particularly our experience as a gastroenterologist. And I hope to share with you not only what we are doing in the city in general, but also as a NYSGE has been a really strong force. And so I'd like to share with you our response and how I think it's been really helpful overall. So this is a view of New York from the top of the World Trade Center, and I think it depicts sometimes how we in New Yorkers feel that we are the center of the world. It may not always be justified, but I think during the time of COVID, it is particularly, it may be a little bit more of a true statement. At least we feel that way, and we definitely know that the world is watching because of how significant the situation has been here. So this is the status of COVID around the world as of yesterday, with 4.8 million cases worldwide. And you can see that the US was leading that with over 1.5 million cases, so almost a quarter of the world's infection burden. And in terms of global deaths, there were over 318,000, with 90,000 of them being in the United States. So clearly, this is the epicenter. And if we put this in the context of even looking within the United States, you can see that the top 6 counties where the most cases are occurring are all centered right here in the New York City region, between New York City, Long Island, Queens, and the Bronx. And the death burden is significant. And if we kind of put that in the context of the world, we can see that when we compare ourselves to other epicenters, New York City alone, the New York City region, far exceeds that of any other region, including ones that you heard from, including Madrid and Italy, by over 2-fold. So clearly, we are an established epicenter, and I believe that it will stay that way. As of yesterday evening, we had a total of 351,000 cases in New York State and 193,000 cases in New York City alone, making up 55% of the state disease burden. Our new cases were 1,250, but if you can see that this is the pattern of our new cases, and clearly we are on the downward slope, and a really nice place on the downward slope that gives us some degree of optimism as we approach reopening. These are our total cases, and here in red are the cases particularly within the New York City region. And again, if you look at deaths, which is certainly a parameter that we've been looking at when we talk about thinking when we can reopen, our peak deaths occurred about in the second week in April. And if you consider probable deaths, because of course we can't confirm all of our deaths, we did reach numbers as high as 800 per day of deaths. Again, there is some optimism, and as we have been going through May, we've really been looking to see when we can reopen. New York State and New York City have created criteria in order to determine when we will be able to reopen. And as you can see, we are nearing that place. We just have a few parameters left, including the new hospitalizations need to drop by just a few points. And we still have a significant number of beds that are COVID positive beds, as well as a significant number of ICU beds that are positive. Here in our hospital system alone, 39% of the patients who are hospitalized for COVID are in the ICU and ventilated. So what's been the response in terms of New York City? Well, one thing that we've definitely seen is very strong leadership, and that was originally guided from around the world. But locally, we have Mario Cuomo and Fauci on a national level who's given us great guidance. And most importantly, in that they give us facts, are fairly transparent about the situation, whether it's a grim situation or whether we can start to have optimism. They provide credible hope with their plans. They do delegate the responsibilities well within the city and to the hospital systems to help respond appropriately, remain flexible in terms of trying to see what will happen in the hospital itself. They definitely examine the needs of citizens, and as we've seen in some cases where nursing home patients have suffered significantly, they've changed and modified the rules in order to manage these situations. And lastly is really fostering community. And within New York, there's a tremendous sense of community that has built up during this pandemic that we will all get through this together. If you look at the timeline of the response, on March 1st was our first confirmed case in New York State, and March 4th it entered New York City. We had a state of emergency declared on the 10th, and then a containment zone in New Rochelle, which was our first hot zone. It's just outside of New York City in the suburbs. The national state of emergency wasn't called until March 13th, as most of you know. In New York City schools were closed on the 15th, which is a very, very big deal because that's just thousands and thousands of students who are now displaced, and has other socioeconomic implications, as a lot of children received food and didn't sort of receive their supervision during that time. On March 22nd, the pause mandate was put in place by Governor Cuomo, which is essentially sheltering in place and closing of all public facilities and not allowing for gatherings. And then April 7th, we had some field hospitals open, and I'll review that in just a moment. And we were hoping that by mid-April, we would end the pause and start to reopen society. However, reassessment of the situation in mid-April caused the governor to extend the pause to May 15th. And then most recently, unfortunately, that pause has been extended even further to May 28th. So as of right now, officially, we are still sheltering in place. I just wanted to give you a sense of the timeline of what NYSGE did to respond, because I think, again, for us here in New York as a GI community, this is our home, this is our sort of family, and I'm very proud of the society for having responded so quickly. So, you know, we turned into a virtual society almost overnight and almost seamlessly. We had a scheduled seminar on March 11th, and you can see here, this is even before the pause is put in place, and we converted that into a virtual seminar and canceled the in-person meeting. By the 16th, we had collected as a group and come up with a consensus guidelines for performing endoscopy during COVID pandemic. This was at the same time and heavily guided by the Joint Society guidelines, but really was a phenomenal effort to provide some guidance to our members. By March 29th, we recognized that the needs of gastroenterologists around the city were changing, and I'll explain that as well later, but we were actually being called back to be internists. And so therefore we had a seminar that actually taught us about treating the medicine of COVID as opposed to treating gastroenterology. And it was a very, very useful seminar, including going over ICU care and ventilatory support, which we have been called to do. By April 2nd, we actually began an entirely new webinar education series for fellows, recognizing that their education was going to be extremely affected, and to bring them together. We've had surveys throughout the city of gastroenterologists to try to determine how COVID is affecting our practices, and those are ongoing throughout the months of April and May. Finally, and recently in May 8th, we actually posted, in line with the other societies as well, guidelines for reopening endoscopy services. And just this past weekend, we had a seminar that updated where we updated everybody on what we've been doing. And coming up on June 2nd, which you're all welcome to join us for, we'll actually have a research symposium that will highlight COVID-19 research that's occurring around the city. So overall in New York, how did we handle the surge? Well, Cuomo mandated that we needed to increase hospital beds to over 100,000, which is basically a 50% increase in hospital beds across the state, but we know that it was primarily centered in New York City. And the ICU ventilators that we needed, he projected needing about 18 to 37,000 ventilators, of which we had 3,000 when we started this entire pandemic. Field hospitals were built, including the Jacob Javits Center. The U.S. Comfort naval ship was brought into New York. The Ryan Larkin Hospital was a field hospital that was built on the Columbia University football stadium, actually, field. And all of this in an effort to increase the New York City's capacity. Within each hospital system and hospital, a significant number of beds were created using creative space such as lobbies, even cafeterias in some areas, space that we would never, waiting rooms, space that we would never have considered to be used for hospital beds. Here at Columbia, we actually increased the ICU capacity by over 100%. And some of the ways we did that was to convert our ORs entirely into ICUs with multiple patients, and occasionally two patients sharing a vent, which is an innovation that had originally been started here. At our peak of COVID here in the New York Presbyterian system, we had 2,600 patients. Now we're less than 1,000, but again, most of the patients who are in our system are very sick and require ICU and ventilator support. What we learned was that we were really shifting as gastroenterologists into internists, hospitalists, intensivists, and that the practice of GI, even within the hospital, was changing dramatically. as we were losing our teams to other services and also being extremely restricted on the way we could practice medicine. So this was a article in CGH that was put together by authors from throughout the city, the large hospital systems, and basically documents how we manage GI consults, for example, GI bleeding, which is really the most common consult that we dealt with. We did everything to maximize non-invasive diagnosis and really held off on any endoscopy for as long as possible, and oftentimes did not even perform endoscopy while in the hospital and had patients be discharged. Nausea, vomiting, and diarrhea, we've learned, were significant symptoms for COVID and therefore treated as if they were COVID-induced, and just treating supportively, but really did not do tremendous workups and definitely did not do any contrast studies, for example, and tried to limit the movement of patients as well as the exposure within our diagnostic services. PEGs were interesting because normally we would expect that PEGs, patients who are ventilated would receive PEGs early as they would receive tracheostomies, but we do notice that vented patients early on had a greater than 80% mortality rate and were staying ventilated for quite a long time. And so PEGs, trachs, those types of things were really deferred for much longer than normal because of the aerosolizing nature of the procedures and the risk to the providers. So we oftentimes sent patients to IR if they did require PEGs, particularly if they were intubated and already had an NG tube in place. ERCPs definitely decreased, and the most common indications were emergent procedures like cholangitis and obstructive jaundice. IBD has a very interesting part of this paper. It's a pretty significant part, and interestingly, I think going in guidelines with the rest of the world, IBDologists were really recommending to treat through the pandemic, and made tremendous efforts to keep infusion centers open and also clean from COVID, and I think made a big difference in their patients. Similarly to changing our consult services, we also realized that we were really repurposing GI units and gastroenterologists themselves. And this is a paper in GIE put out by the NYSGE Research Committee that looked at the impact of COVID on how we changed sort of endoscopy practice. So here you can see hospitals became, the majority of the hospital, over 80%, became COVID positive, and a significant portion even became ICU. Again, as I mentioned, the hospital capacity increased tremendously, and all of this capacity required deploying every available healthcare worker, including attending gastroenterologists, fellows. Med students were graduated early to become residents, and fellows were graduated early, and residents were graduated early to actually become attendings, not only of floors, but even of ICUs. If we looked at what happened with endoscopy, you can see that the volume dropped tremendously, particularly for community hospital and endoscopy units, to less than almost 10%. And hospital endoscopy units also dropped significantly, and most of these were just emergency cases. In terms of physicians performing procedures, clearly there was a significant drop both in attendings and fellows. Fellows were almost universally did not perform any procedures, certainly no procedures in COVID positive patients, but for the most part, endoscopy was limited to 1 to 2 attendings per unit, decreased exposure. Just a sense of the procedures that we did do, what they were in, the indications were, you can see bleeding was the most common indication for endoscopy, and cholangitis, obstructive jaundice were the most common indications for ERCP. EUS was still performed, usually in the setting of need for tumor biopsy in order to get patients to unexpected neoadjuvant therapy, because no patients could really undergo surgery since our ORs were turned into ICUs. Even our surgeons in particular were unable to perform surgeries on patients who had surgical resectable disease, and therefore we were thinking our oncologists were being creative about treating these patients, and did require tissue. So that did become an indication for EUS when there was some ability to change their management in the immediate future. Colonoscopies dropped significantly. It was mostly for bleeding, and particularly in the hospital for urgent cases, we did not really perform this and tried to maximize non-invasive care. We do have some data. We will have actually a significant amount of data on GI manifestations of COVID-19. And by this point, this is coming from around the world, so it's nothing new. But this was a very early look at what was happening here. And kudos to our fellows for pulling this together quickly. But they did a study comparing 278 positive COVID patients to 238 negative COVID patients, found that overall COVID positive patients were presenting 35% of the time with GI symptoms of nausea, vomiting, and diarrhea. And that patients who presented with GI symptoms at the time of their testing were more likely to test positive than those who did not have GI symptoms. In addition, GI symptoms with COVID were associated with a 70% increased risk of testing positive, or associated with a longer illness duration compared to those that did not have GI symptoms. However, did have a lower risk of death and tended to be less critically ill with decreased rates of ICU admission. And we will see, like I said, a lot more research coming out, and I do invite you to join us on June 2nd as the NYSGE Symposium. So with COVID-19, we've seen leaders in the GI world emerge from around the world with giving us very valuable information and guidance, including Repurposing's article, which I think has led everybody to help them with their policies. Our National GI Society leaders from the ACG, AAGA, and ASGE, who these individuals were all with us this past weekend. But on a very local level, we really rose to the occasion as a GI society with the NYSGE and tried to provide similar guidance. We took the lessons from elsewhere, including the experience from how to perform endoscopy, and we actually created our own GI guidelines for endoscopy early on. And then similarly, we watched what was happening around the world as the pandemic was leaving these places and the information they could provide with us regarding transmission, for example, and proposals to return to routine endoscopy. And we similarly came up with guideline statements for reopening endoscopy. As I mentioned, I think NYSGE rose to the occasion. They maintained their mission goals, which were education, training, advocacy, and research. Education, we've always had seminar series, and the annual course, which is probably the largest live course in the country. Training, we have fellows nights and hands-on courses. Advocacy occurs at a state level, and research has always been a strong portion of us. We are a very large society with nearly 600 members of all different types and different practice types. So it's important to keep that in mind as we go along, and we try to remember that we need to speak to everyone's needs. Some of the initiatives we did is to start the medicine seminar I mentioned, converting the society to a virtual platform, and maintaining a schedule that we had put in place without any interruption, as well as sharing webinar opportunities around the city and around the world. In terms of training, we started an entirely new webinar series focused for fellows. And on the research side, I've mentioned to you what we've done with upcoming highlights in that. For guidelines, the original guidelines for endoscopy units we posted on the March 16th. They spoke to PPE use, endoscopy unit flow, procedure indications, recommendations for trainees, and introduction of telehealth into our practice, which was a relatively new thing. Unfortunately, we couldn't really comment on ASCs because we didn't have a lot of experience or know what to do or experience from around the world. But as you'll see, when we gave the second set of guidelines, again, we really spoke to our needs. These are available in those guidelines. These are all available on the NYSGE website, and I invite you to visit that website to see any of them. But early on, you can see this is probably what matches any of your practices in terms of the procedures that were still done during the peak of COVID. And then again, when we talked about reopening endoscopy in post-peak New York, we very much looked to the guidelines given out by the national GI societies, but tried to be a little bit more local, specific to our local situation, talking about patient and staff screening, what was available with regards to resources like testing and PPE. And we also spoke specifically to ASCs, as they are a little bit of a different situation, not necessarily supported by hospital systems. We commented on things that we hadn't otherwise taken into consideration, such as extra time for cleaning and PPE, thinking about PPE fatigue when we're performing these procedures, and at-risk providers. And mentions about patient follow-up and consent. And one of the research projects that we will try to do here in the city is to survey the rate of transmission to providers and patients as we go forward. There are some things to note in making any of those recommendations, and I think that national societies have noticed this as well, is that one size does not really fit all, and there's significant variations. And even my discussion with Nagi at the beginning of this, I think testing availability and PPE availability will make a big difference. And those guidelines will be updated real time. And just as a mention of advocacy as a society, we actually supported a letter to Governor Cuomo that asked for our ASCs to be considered as a place to be able to perform elective or semi-elective procedures as we reopen, which he had not actually said was the case. In my own personal experience, as we're trying to plan this reopening, I can tell you that time delays are significant, both because we do test patients here at our facility. All patients undergo testing, and patients can be positive, and in that case, everything is really disrupted and the case is canceled. Even just putting on and taking off PPE, cleaning the rooms, if they're positive patients, it requires at least half an hour, and otherwise still takes quite some time. Resources are very slow to return. So our unit was not turned into an ICU, although that was the case in many of the units around New York State. However, everything else was taken from us, including our nurses, our staff, our monitors. And so those resources have been slow to return, and those are some things that we don't normally take into account when we think about our capacity to perform endoscopy. And then most importantly, we are finding that patients are very hesitant to return in all fields of medicine, and we have wondered, where are patients who are having heart attacks, and they've really been sitting at home. Patients have been bleeding at home, and when they do present now to the hospital, it's with pretty significant bleeds and significant hemoglobin. So this will be an interesting as it unfolds. Again, just my personal recommendations about how to handle COVID-19 in the surge, which hopefully has passed for all of us. I certainly hope for you, and reopening, remaining honest and transparent as possible, not only regarding your data of infection rates to help guide how you will respond, but also sharing of data across the world, as we have all done with regards to things like PPE and GI manifestations. Maintaining frequent communication, as you seem to be doing with these weekly seminars, and really fostering a community. For us, that community is GI. We look to our larger societies clearly for guidance, such as our national societies and our world societies, but we do have to remember to tailor to local needs and resources, and really remain consistent in our ultimate goals, which are patient safety and provider safety, and try to figure out how we can share those resources, and even consider maybe even sharing practices in order to be able to maintain those goals, but still return to being able to provide care for our patients. You have to be open to changes in paradigms and treatment strategies, which I think is something that will unfold over the next year or two in terms of the way we perform endoscopy and the types of procedures and techniques that we use. And again, this is my term, medical resocialization, may be just as difficult as encouraging isolation for patients. And so I think this might remain our limiting step. This is the 7 o'clock happy hour that occurs every single day in New York. And you can see I'm on the 28th floor, how loud it is. And it's something that we are all incredibly proud of. It is an emotional moment for all of us. Particularly as healthcare workers, and it's something to look forward to. I will just share with you, this was created by one of the fellows at New York at Sinai. And I think messaging like that will need to continue from us if it even as we shift into this phase of trying to bring patients back home to our units. So from New York, peace, love, and endoscopy, and thank you again for this opportunity to share with you our experience in New York.
Thank you, Amrita, for that fantastic overview of what's happening in New York. In fact, you showed us many leaders in your talks, but I think you are a true leader leading the New York Society of GI Endoscopy at this very critical time, and this was a very appropriate talk. As expected, there is not only a large viewership but large number of questions, but I know that you have some procedure coming up soon.
You can continue. I'll let you know when I need to go.
Yeah, so I'll just give 2-3 questions that are very common. And the first was, you mentioned that the younger fellows are not doing endoscopy more, and it's the consultants. The general feeling here was, at least in India now, is that those of us who are above 65 are excused from endoscopy, and these younger people are going to do more endoscopy because of this fear that the older people have more severe disease. But this seems to be different in New York now.
Yeah, there's 2 reasons. One is because, as I mentioned, everybody was really redeployed. So almost all of our fellows have served as intensivists, actually as attendings in the ICU, both during the day and at night. They've been in our ERs, they've been on our general medicine services. We ourselves have served on the medicine services as general medicine attendings. I did a week, as have many of my colleagues, also even been in the ICU, which I think is really impressive, and a return to a medicine that we did not know from a long time ago. So part of it had to do with just staffing. The younger the fellow, the more in touch they were with medicine, and the more actually they're capable of handling the hours and just the work that went into that. And my hats are off to them completely for what they've endured. At the same time, we were also very protective of our providers who might be at risk, including those over 65. But that was actually possible because of the significant reduction that we had in endoscopy. So across the board, we really were, all the hospitals were really just employing 2 people. It was usually a general medicine attending and an interventionalist who were doing all the procedures, including the COVID-19 procedures, and trying to really limit even how many people were in the unit during the surge. So that wasn't a problem in terms of staffing endoscopy, and we were able to protect on both ends, provide workforce where it was needed, and to protect our more senior at-risk endoscopists. As we return, I think it's something that we really need to think about, and the guidelines that we wrote for New York on reopening speak to that a little bit. I think that to a certain extent, some people aren't ready, they're not aware of what they're going to get into. The PPE fatigue is very significant, and I'm sure if you've been scoping and have worn it all the time, it really does limit you. It's an exhausting day to be in that all the time and to be doing your procedures with the mentality of just trying to get through them. And so I think that for those who are not used to that kind of a day, to a certain extent as interventionalists, maybe we do a little bit more in terms of our volume, so we're used to it. But I think for those who are not used to it, it is something to take into account as they rebuild their volume, and to really utilize their junior partners to help them manage that volume, so that again, we can bring patients back at a good pace without putting ourselves at risk. Because I think the later that we reopen, the later if one gets sick, the more detrimental it is to your practice, because now things are able to normalize. And if you are out for 14 days or, God forbid, get very ill, that's significant injury on your practice.
Another question coming in, Amrita, is regarding PPEs. What is the policy in an institution that you wear the full PPE for every patient or only for COVID positive patients? Is there a difference in how you are treating both of this, or are you looking at every patient as a potential PPE? The reason I'm asking this is because in India there is a concern that asymptomatic carriers may be large, and we're not testing everybody before the procedure. So is there a danger, or should everybody wear the full PPE?
Yeah, I think that's a great question. As in terms of the hospital policy, everybody wears surgical masks. And it's only the aerosolizing procedures or the high-risk situations in which, for example, treating COVID-19 patients, in which the full PPE is recommended. And we have not had a problem with availability, but everyone is, very aware that the availability of certain PPE might diminish. And if we have a resurge, we really do have to be careful about making sure that people are wearing appropriate PPE when it's needed and not using it when it's not needed, so that we have it for those who do need it. In terms of endoscopy, we are recommending full PPE for all cases, regardless of whether they are negative or positive. Again, we have the PPE available. The way it changes for a positive patient is that we perform the case in a negative pressure room, whereas negative patients are performed in a regular room and have the consequent sort of amount of time after the procedure. And similarly, so for now, we're treating everybody like they're positive, but things like follow-up and whatnot after that are treated differently depending on whether they're positive or negative. It does depend on whether you're going to test. So we also test all patients, but I think a lot of places do not have testing available to them. And so this will make a difference, because if you don't have testing, I think it's more important to treat everyone like they're positive. If you have confirmation of testing, even though there are a lot of false negatives, I think there's a little bit more safety in not wearing full PPE for everybody. Colonoscopies, I don't think require it. I think that's been demonstrated, and for particularly these small centers that don't have availability of all this and may have providers who are at risk, they're actually starting with colonoscopies in terms of when they reopen, as opposed to endoscopies. Any COVID positive patient should really be sent to a institution that's capable of treating that with negative pressure rooms and has availability of full PPE.
Yeah, as you said that wearing these PPEs can be extremely tiring to do procedures, because it's after 3-4 procedures you feel very tired.
Yeah.
Finally, one more before you leave. One question is, in New York, what is the percentage of healthcare workers in the endoscopy area developing? Are they at an extra risk developing, transmitting this, or is it same for all healthcare workers?
Yeah, we don't have the data available yet. That's one of the surveys that we are hoping to do as a society. We have not heard of increased numbers of providers getting positive within the endoscopy unit. Again, keep in mind, all of our staff, every single nurse has been deployed somewhere else in the hospital. And so we do have a significant number of nurses who have had to stay in isolation, or staff stay in isolation, or even our fellows. But I think this is primarily because they were on the front lines in the ERs and the ICUs, not necessarily, it wasn't up here in endoscopy that caused that transmission. And I think that kind of data emerging from around the world, and particularly locally, is going to be key to bringing patients back and also making providers feel safe. For us.
Thank you, Amrita, for this fantastic talk. And for the viewers, Amrita has been the recipient of this year's Master Endoscopist Award from the ASGE. I'd like to congratulate her, and thank you very much for being part of this symposium.
Thank you so much.
Thank you.
Bye, everyone. Stay
Bye.
safe.
Bye.